Hello, and thank you for tuning in. I'm Bani Jolly, a senior scientist at Kalkinos Healthcare, and in this video, I'll be speaking about what comprises a genetic test report, specifically how pharmacogenomics, carrier status, and incidental findings can be reported in genetic tests. Let's start with an interesting historical anecdote. Here we have Pythagoras, the famous ancient Greek philosopher and mathematician. Pythagoras was known for many things, but one curious fact about him is that he had a very strong aversion to fava beans and thought they could take a person's life away. It turns out there is a medical reason behind this unusual fear. A condition known as G6PD deficiency is a genetic disorder affecting red blood cells. For people with G6PD deficiency, consuming fava beans can lead to a severe reaction called hemolytic anemia. This condition highlights how genetic differences can impact health. This brings us to the core of our discussion, the myth of the average patient. In medicine, there is often an assumption that treatments and medications work the same way for everyone. However, just as someone's unique genetic makeup can affect their reaction to fava beans, each patient's individual characteristics can influence how they respond to medical treatments. A one size fits all approach in medicine is not only ineffective but can sometimes be harmful. Personalized medicine, which tailors treatment to individual specific needs, is becoming increasingly important as we understand more about these variations. Let's move on to a more somber but crucial topic when treatment becomes toxic. Dr. Anil Kapoor, a 40-year-old physician, was diagnosed with stage 4 colon cancer. His doctors prescribed a treatment plan aimed at extending his life. Part of this treatment included using 5-fluorouracil or 5-FU, a commonly used chemotherapy drug. Unfortunately, Dr. Kapoor passed away just weeks after starting his treatment. The cause was not the cancer itself, but a toxic reaction to the chemotherapy drug 5-FU. So, what went wrong? In Dr. Kapoor's case, pre-screening failed to identify a genetic variant that significantly increased his risk of severe toxicity to 5-FU. This variant, if detected, would have indicated the need for a different treatment plan or a modified dosage. This story underscores a critical point, the importance of personalized medicine and thorough pre-screening. Genetic variations can profoundly impact how patients respond to treatments, and missing these variations can lead to catastrophic outcomes in certain patients. In fact, it is reported that 10 out of 1,000 patients in the USA itself die from 5-FU toxicity, all of which is largely avoidable by comprehensive pre screening. Dr. Kapoor's case is thus a reminder that treatments need to be tailored to the individual, taking into account their unique genetic makeup. If we take a closer look at the concept of imprecise medicine with some compelling statistics, this chart illustrates the percentage of patients for whom various classes of medications are ineffective. Cancer drugs are ineffective for a staggering 75% of patients. This means that 3 out of 4 patients undergoing cancer treatment do not receive the intended benefit from their medication. These stats highlight the urgent need for personalized medicine. Traditional one-size-fits-all approaches to treatment often fall short because they don't account for the unique genetic makeup of each patient. Personalized medicine aims to tailor treatments based on an individual's specific genetic profile, and by doing so, we can increase effectiveness of treatments, reduce adverse effects, and ultimately improve patient outcomes. To explain how pharmacokinetics and pharmacodynamics work, let's examine the metabolism of fluoropyrimidines, specifically 5-fluorouracil or 5-FU, a key chemotherapeutic agent. This diagram illustrates the metabolic pathway of 5-FU, highlighting its biotransformation within the body. 5-FU can be administered either directly or synthesized from prodrugs such as capecitabine and tegafur. Upon administration, 5-FU undergoes extensive metabolic processing. A minor fraction, which is only 1 to 3%, undergoes anabolic conversion to active metabolites that exert cytotoxic effects by incorporating into RNA and DNA, thereby disrupting nucleic acid synthesis and function in malignant cells or tumor cells. However, approximately 80 to 85% of the administered 5-FU is actually inactivated and eliminated during its metabolism. The DPD enzyme is integral to this metabolic pathway, and genetic polymorphisms in the DPYD gene can thus significantly reduce enzymatic activity, leading to elevated systemic concentrations of 5-FU and consequently increasing the risk of severe toxicity. The DPYD gene, located on chromosome 1, encodes the enzyme DPD. This enzyme plays a crucial role in the metabolism of fluoropyrimidine drugs such as 5-FU and its prodrugs like capecitabine and tegafur. DPD is responsible for the breakdown of these drugs, ensuring their proper inactivation and elimination from the body. The activity of this enzyme is thus pivotal in determining how a patient metabolizes and responds to fluoropyrimidine based chemotherapy. Genetic variations or polymorphisms in the DPYD gene can thus lead to reduced or absent DPD enzyme activity. And patients with such variants are at a significantly higher risk of severe toxicity when treated with standard doses of these drugs. This can result in life threatening side effects as their bodies cannot effectively process and eliminate the drug, as evidenced in the case of Dr. Anil Kapoor. The US FDA has recognized this risk and added warnings to drug labels for 5-fluorouracil and capecitabine, advising against their use in patients with DPYD deficiency. Furthermore, ESMO guidelines also recommend germline testing of DPYD before administering fluoropyrimidines. Pharmacogenomic testing for DPYD variants can identify at-risk patients, allowing healthcare providers to adjust chemotherapy regimens accordingly. This may involve reducing drug dosages or selecting alternative treatments to mitigate the risk of severe toxicity. According to data analyzed as a part of the Indigen project, approximately 3% of the population in India is at an increased risk of 5-fluorouracil toxicity due to DPYD variants. Additionally, about 10% of the population may require a reduced dose of DPYD to ensure safe and effective treatment. In fact, the impact, applicability, and utility of pharmacogenomics extends beyond the DPYD gene in India, and it is estimated that on average, each Indian individual carries 8 clinically actionable pharmacogenomic variants. Incorporating pharmacogenomic testing into routine clinical practice across India can thus lead to more personalized and effective treatment strategies. Understanding clinically actionable genetic variants is crucial for advancing personalized medicine. And when we talk about what may comprise these clinically actionable variants in a genetic report, these can be pharmacogenomic variants, secondary findings, and variants indicative of a carrier risk. There are 306 variant or haplotype drug combinations in 29 genes that have clinical actionability, classified as level 1A or 1B variations by Pharm-GKB. These variants can inform drug selection and dosing, helping to maximize efficacy and minimize adverse effects. Secondary findings are another critical category. The American College of Medical Genetics and Genomics, or ACMG, provides guidelines on reporting these findings. The ACMG secondary findings list, version 3.2, comprises 81 genes, and these genes are associated with over 90 disorders, including cancer predisposition, cardiovascular diseases, and metabolic conditions. Identifying disease causing variants in these genes can provide essential information for disease prevention and management, even if they are unrelated to the primary reason for genetic testing. Lastly, carrier status reporting includes pathogenic or likely pathogenic germline variants linked to inherited disorders. Identifying these variants is vital for understanding an individual's risk of passing on genetic conditions to their offsprings. Integrating the reporting of these clinically actionable variants into routine clinical practice enables more precise and personalized healthcare. And each component of these genetic reports have different guidelines to ensure accurate and comprehensive reporting. Clinical pharmacogenomics guidelines are essential for helping clinicians understand how genetic tests should be utilized to optimize drug therapy. These guidelines provide a standardized system for grading levels of evidence that link genotypes to phenotypes. And this system ensures that clinicians can make informed decisions based on the best available scientific evidence. Several organizations contribute to the development and dissemination of these guidelines, including the CPIC, Royal Dutch Association for the Advancement of Pharmacy, or the Dutch Pharmacogenetics Working Group, or DPWG, the Canadian Pharmacogenomics Network for Drug Safety, CPNDS, and others. PharmGKB is a key resource in this field, providing a comprehensive database that includes pharmacogenomic information and guidelines from all these organizations. PharmGKB also provides a comprehensive framework for categorizing the level of evidence supporting drug variant pairs. And understanding these evidence levels is crucial for integrating pharmacogenomic information into clinical practice. PharmGKB characterizes the level of evidence supporting drug variant pairs into 4 tiers. Level 1, which is the high level of evidence, wherein level 1A variants are those supported by clinical guidelines or FDA labels with at least one publication. And 1B are those that have strong evidence without any specific prescribing guidance but backed by at least two publications. Level 2 are variant drug pairs having moderate level of evidence. Level 3 are variants having low level of evidence, and level 4 are variants having insufficient evidence to support a clinical association. This system helps clinicians use pharmacogenomic data to guide drug prescribing, enhancing patient safety and treatment outcomes. PharmGKB level 1A and 1B represents the highest level of evidence for pharmacogenomic variants. And this level includes a total of 29 unique genes such as CFTR, HLA-B, CYP2D6, DPYD, and TPMT. And it includes 98 unique drugs which are influenced by genetic variants in these genes, and 194 unique variant haplotypes that may affect drug response. These variants are critical for understanding how drugs can increase or decrease the risk of adverse drug reactions, how genetic information can guide whether a lower or higher dose of a particular drug is necessary, and how variants can predict an increased response, a responder status, decreased or limited response, no response, or an unknown response to a particular drug. Incidental or secondary findings are genetic variants that are unrelated to the reason for ordering the sequencing but hold significant medical value for patient care. According to ACMG Secondary Finding List version 3.2, these findings include or encompass 81 total unique genes such as BRCA1, BRCA2, TP53, and so on, in four unique phenotype categories, encompassing 50 unique disorders and phenotypes, such as cancer predisposition, cardiovascular diseases, and metabolic conditions. These genes are selected because pathogenic variations in them can lead to serious but potentially actionable health conditions. The list is periodically reviewed and updated by the ACMG to incorporate new findings and advances in medical genetics. According to ACMG guidelines, we should report pathogenic or likely pathogenic variants to patients when they are found in the genes listed in the list given by ACMG. During any kind of germline analysis, such as whole exome sequencing, whole genome sequencing, or in normal samples when paired with tumor normal analysis. Importantly, this reporting should be done irrespective of the patient's age, although it is specifically mentioned to exclude fetal samples. Carrier screening is a vital component of genetic testing aimed at identifying individuals who are heterozygous for pathogenic or likely pathogenic variations in autosomal recessive or X linked conditions. Carrier screening involves molecular testing of individuals and couples who are at risk of having a child with an autosomal recessive or an X linked genetic disorder. This screening is crucial for providing prospective parents with information about their carrier status and the potential risks to their future children. Understanding these inheritance patterns and the implications of carrier screening helps in making informed reproductive choices and managing the health of future generations also. ACMG provides comprehensive guidelines for carrier screening, which are categorized into different tiers based on carrier frequency and risk of a particular disorder. Tier 1 includes risk based screening for conditions such as cystic fibrosis and spinal muscular atrophy. Moving to Tier 2, this involves screening for conditions with a carrier frequency of 1 in 100 or higher, which includes all the conditions from Tier 1 also. Tier 3, which is recommended, expands the screening to conditions with a carrier frequency of 1 in 200 or higher and includes conditions from Tier 2 also and encompasses X-linked conditions specifically covering 97 autosomal recessively linked genes and 16 X-linked genes. Tier 4 involves screening for conditions with a carrier frequency of less than 1 in 200, including those from Tier 3. Although testing is optional, it is recommended by ECMG that preconception testing should be done rather than testing during pregnancy. Additionally, in cases of consanguinity or significant family history, the risk increases, making screening much more critical. The ACMG recommends Tier 3 testing or Tier 3 screening for all pregnant patients and those planning a pregnancy. Tier 4 screening is specifically recommended for cases involving consanguinity or a significant family history. However, routine offering of Tier 1 and Tier 2 is not recommended by ECMG because lack of equitable evaluation across all racial and ethnic groups. Similarly, routine offering of Tier 4 screening is also not recommended by ECMG. These guidelines are designed to ensure that carrier screening is tailored to the individual's risk and genetic background, thereby enhancing the relevance and effectiveness of the screening process. When it comes to genomic testing, there are several different options available, each with its own range of utility and applicability. Array or genotyping covers a small portion of the genome, around 0.01 to 0.05% of the bases. This method is limited to known and frequent variants, making it very less comprehensive. Whole exome sequencing, on the other hand, focuses on the exome, which is the protein coding part of our DNA, and represents about 1 to 2% of the entire genome, where majority of known disease-causing mutations may lie. Whole exome sequencing covers fewer bases compared to whole genome, but still offers substantial evidence and clinical applicability. It is particularly useful for diagnosing genetic disorders where causative mutations are expected to be in the exonic regions. However, it still misses out in over 98% of the genome of the patient genomes. Whole genome sequencing, on the other hand, covers almost all bases in the genome, and this comprehensive approach offers the highest level of evidence applicability, clinical applicability, new evidence applicability, and discovery potential. WGS is ideal for identifying both common and rare genetic variations, providing a thorough analysis of a patient's entire genome. If you look at the various type of variants and the traditional standard of care tests that are used to detect them, for chromosomal abnormalities, for example, which involve millions of bases, traditional tests include karyotyping, and these tests take typically 2 weeks or more to complete. Structural variants ranging from thousands to tens of thousands of bases are also detected using techniques such as FISH and MLPA. Repeat expansions, which involve tens to thousands of bases, are identified using techniques such as repeat prime PCR. Small variations are identified using panel sequencing, including whole exome sequencing and capillary sequencing, with results taking 2 to 4 weeks. By utilizing whole genome sequencing instead, we can consolidate all these various tests into one comprehensive process, significantly reducing time and cost associated with genetic testing. WGS provides a comprehensive analysis that includes chromosomal abnormalities, structural variants, repeat expansions, deletions, insertions, and single nucleotide variations. This not only streamlines the diagnostic process but also provides more timely and accurate results for clinical decision making through one single test. Whole genome sequencing or WGS offers significant advantages in pharmacogenomics also due to its comprehensive analysis capabilities. One major advantage of using WGS is its ability to detect non-exonic variants in important pharmacogenes such as DPYD, VKORC1, IFNL3, and IFNL4. This is crucial because many clinically relevant variants are found outside exonic regions of these genes. WGS also covers mitochondrial DNA pharmacogenomic variants, providing a complete genetic analysis. Additionally, WGS offers accurate HLA genotyping, which is essential for various drug responses and adverse reactions. Another strength of WGS is its ability to detect structural variations in important pharmacogenes, such as those found in CYP2D6 and G6PD. These variants can significantly affect drug metabolism and response, making their accurate detection very vital for personalized medicine. In contrast, whole exome sequencing misses some very critical elements. WES does not effectively capture intergenic, intronic, and UTR variants in important pharmacogenes. These regions can contain regulatory elements and other important genetic information that can influence gene expression and drug response. Furthermore, WEX actually misses 12 of the 123 farm GKB level 1A and 1B SNVs, including mitochondrial variations. Accurate and complete genotyping of key pharmacogenes such as CYP2D6, CYP2B6, UGT1A1, TPMT, CYP2A6, and CYP3A4 is also more challenging with WES as compared to WGS. Overall, whole genome sequencing provides a more comprehensive and accurate genetic analysis for pharmacogenomics, capturing a broader range of variations that are crucial for understanding drug response and optimizing personalized treatment. WGS, in fact, as a primary clinical test, has been shown to provide a higher diagnostic yield than conventional testing techniques, especially in clinically heterogeneous cohorts. This finding, highlighted by Lionel et al. In a 2018 study published in Genetics in Medicine, underscores the value of WGS in delivering more accurate and comprehensive genetic insights. The integrated process of WGS, reporting, and genetic counseling ensures that patients receive the most precise and relevant genetic information, empowering them and their healthcare providers to make informed decisions about their health. In conclusion, pharmacogenomics plays a crucial role in personalizing medicine based on an individual's genetic profile. By understanding how a person's gene affect the response to drugs, we can tailor treatments to improve outcomes, enhance safety, and this approach minimizes adverse drug reactions and maximizes therapeutic efficacy. Carrier screening is another important aspect of genetic testing. It identifies genetic risk for inherited disorders, which is vital for informed family planning. By knowing the carrier status, individuals and couples can make educated decisions about their reproductive options, helping to prevent transmission of genetic conditions to their children. Incidental findings from genomic tests can reveal unexpected genetic information. These findings, when are unrelated to the initial reason for testing, must be handled ethically well and communicated appropriately. Patients should be informed about the potential implications, allowing them to make knowledgeable decisions about their health and lifestyle. Whole genome sequencing offers a comprehensive analysis of an individual's genetic makeup in a single test. Unlike more targeted approaches, WGS provides a broad view that includes non coding regions of the genome also. This thorough examination helps identify relevant genetic variations that might otherwise be missed, providing valuable insights into individuals' health and potential risks. In summary, these various facets of genetic testing, pharmacogenomics, carrier screening, incidental findings, coupled with whole genome sequencing, can collectively contribute to a more personalized and informed approach to healthcare. By leveraging genetic information, we can enhance treatment outcomes, make informed reproductive choices, handle unexpected findings ethically, and gain comprehensive insights into our genetic health. Thank you for paying attention.